Good afternoon. I'm Cindy Hall, president of the Women's Congressional Policy Institute. Welcome. This is our annual lunch event for women veterans, an event that we've done for almost 20 years. And we have hosted this event in partnership with DAV for almost all of those 20 years, I think, maybe except the first. And this year's focus is on women veterans' mental health, suicide prevention, and intimate partner violence, or IPV. As most of you know, WCPI is a nonpartisan, nonprofit public policy organization whose mission is to bring together a bipartisan community of women policymakers and trusted partners to advance issues of importance to women and their families, develop the next generation of women leaders, and foster a more effective and representative democracy. And our chief stakeholder is the Bipartisan Women's Caucus. Today, we will be hearing from a very distinguished panel within the veterans community, including Dr. Jennifer Kinetic, Jennifer Alvarado, and our moderator, Naomi Mathis. Each of them will bring a different perspective to this important and necessary discussion, and we thank them for participating. Our special thanks also to Otsuka America Pharmaceutical Inc. for their support for this briefing. We appreciate their commitment to women veterans' mental health and their work to research and develop treatments to improve the lives of people with brain health conditions. I would like to thank the Congressional briefing co-sponsors, the leadership of the Bipartisan Women's Caucus, Congresswomen Kat Cammack and Susie Lee, co-chairs, and Congresswomen Monica De La Cruz and Amelia Strong-Sykes, vice chairs. And of course, again, our thanks to our longtime partner, DAV, Disabled American Veterans. We are grateful to DAV for their partnership and work on behalf of women and all veterans. Before we begin, on behalf of WCPI and our partners today, I would like to thank any attendees who have served or are currently serving in the military. If there are any current or former service members, and I know there are many here, please stand. I also want to recognize the many veterans who I know are watching the live stream. Thank you to each of you for your service and for joining us today. We will not forget. This event will continue for years to come. We will be posting live on social media during this briefing. We encourage you and others to do so by using the hashtag WCPIVets. I'm now very pleased to introduce Congresswoman Lucy McBath, who is a former Democratic Vice Chair of the Bipartisan Women's Caucus. She's serving her third term representing the 7th District of Georgia. She serves on the Judiciary and Education and Workforce Committees and comes from a family of veterans. We've been talking about the many family members. Her bill, the Haven Act, which protects veterans in need, was signed into law by President Trump in 2019. She continues her bipartisan work on behalf of veterans, and we are so thrilled to have her with us today.
Well, thank you so much. I'm really, really honored to be here. I am Congresswoman Lucy McBath of Georgia. I currently represent Georgia's 7th Congressional District. We'll be moving to the 6th Congressional District. My joke is if you hang around long enough, I'll be representing New York, LA, California. But anyway, on behalf of my colleagues here in Washington and all the families across the nation, we extend our sincerest gratitude to all of you that have served on behalf of our country. Thank you so, so very much for your service and for your selfless sacrifices, and those of your families as well, because what I always like to say, it's not just those that have actively served as the men and women in our military, but the families serve right alongside with you. So thank you to all of the families that have been supportive as well. Each and every day, Americans and their loved ones, they go about their lives with the full security of knowing that threats abroad are kept at bay thanks to the brave men and women that serve in our armed forces. For the next generation of women in this country, countless young girls look to your example. That a woman's place in America is limited only by the scale of her dreams and the depths of her determination. To your loved ones, to all the women that have served this country, to your loved ones, we'll never be able to fully thank their role in engaging you from home. As the daughter of an Army Dental Corps veteran, my father served in the Korean War in the Army Dental Corps. He's one of the first African-American dentists to do so. I know from my childhood that the lifestyle of a service member is demanding, both during and after their time in uniform. And as a member of a military family today, I know that the challenges facing our nation's security and military are ever evolving, even as we speak. So thank you for being our nation's vanguard in ensuring that our strength stays ahead of the threats of tomorrow. Thank you for your sacrifice. Thank you for your visionary leadership. Thank you for standing guard as our armor bearers of freedom. And as you spend time in Washington, I want to echo the work of the Women's Congressional Policy Institute and reiterate how urgently our nation needs your voice over these next few years. Issues such as maternal mortality and countless others need our voice at the table if America is to continue pressing forward on the path to progress. And no other voice can best advocate for our nation's faithful veterans than those who have actually served themselves. Our role as elected officials depend on individuals such as yourselves to amplify solutions that we can then put to paper. I'm very proud of the work of the Bipartisan Women's Caucus, the Women's Congressional Policy Institute, and the Disabled American Veterans have accomplished, and what they will continue to do in the coming future, in the coming months, to serve the interests and the needs and the safety of the American people. I want to encourage every one of us in this room, but all those that are watching, to ask the questions and offer our dialogue as we spend time here and learn more about the processes that we all pledged oaths to protect. Thank you once again for honoring us with your patriotism and your presence, and you're willing to stand up and be the armor bearers for this nation and all other nations across the world that are depending on us. And I look forward to seeing what we accomplish, what you accomplish, because I know together we will get it done. Thank you and God bless.
Thank you so much, Congresswoman McBath. It has been such a pleasure for us to work with you over many years, and we are so grateful for your interest in actually getting things done here, working in a bipartisan way, and making this issue, women veterans, and military, such a priority in your work. So thank you. Well, I am now pleased to introduce Naomi Mathis, Assistant National Legislative Director at DAV, who will be our moderator. As a senior member of DAV's legislative team in DC, Naomi works to advance legislation and policies critical to disabled veterans and their families. While in the Air Force, Naomi deployed 3 times to Iraq and Kuwait and attained the rank of Staff Sergeant before being medically retired in 2007. Naomi, we are thrilled to have her again. She's been a speaker or involved in some way with this event for so long.
Thank you, Cindy. It's my honor to be here with you today and to discuss suicide prevention and intimate partner violence among women veterans. First, I'd like to thank the women that have served, who are here and online, and who signed up to serve their nation. Your service isn't always recognized or appreciated the way it should be, but the people that are here in this room and online, we see you and we do appreciate you. I also want to thank Otsuka for sponsoring today's event. The work that you do is important in reducing barriers to necessary medications and destigmatizing the mental health care in our nation's veterans. Finally, I want to thank the Women's Congressional Policy Institute and the Bipartisan Women's Caucus. Your collaboration helps to ensure that we are pushing forward the issues that matter most to our unique population. DAV's mission is to empower veterans to lead meaningful lives with dignity and respect. DAV does this by providing no-cost professional benefits, claims assistance, fighting for veterans' interests on Capitol Hill, offering employment and entrepreneurship resources, and educating the public about the great sacrifices and needs of veterans transitioning back to civilian life. DAV also recognizes that some in our community historically have been overlooked. Women have served since the Revolutionary War, going to great lengths to disguise themselves as men for the chance to defend their nation. And yet they remain unrecognized and underserved even today. Much has changed since the 18th century, of course, but progress has not been fast enough. It's hard to believe, but it wasn't until 2013 that the ban on women in combat roles was lifted, finally allowing them to serve unencumbered. Though I myself served in combat in Iraq in 2003. So that shows you how women have been sacrificing our lives far longer than that. It's not just the military that has had to play catch up in order to ensure women can serve and contribute to the defense and security of our country, but the Department of Veterans Affairs, the very institution charged with caring for our veterans, must continue to adapt to the changing demographics of those who return home forever changed by service. It is critical that we get this right sooner rather than later. Lives are quite literally at stake. According to the latest VA data, the suicide rate among women veterans jumped nearly 25% between 2020 and 2021. That's vastly higher than their male and civilian counterparts. Earlier this year, DAV released its special report, Women Veterans, The Journey to Mental Wellness. It is one of the most comprehensive assessments of the unique factors contributing to the staggering increase in suicide among women veterans and how the VA can and must do better. Using the latest in research and data combined with a thorough review of the VA's available services, this in-depth report reveals that too many veterans are at risk of falling through the cracks due to gaps in life-saving mental health care. In response, DAV put forth over 50 policy and legislative recommendations related to access to mental health care, training requirements for providers, suicide prevention efforts, gender-tailored care, and more. These recommendations are intended to spark necessary and urgent change, and we will work side by side with the VA and Congress to make sure that that happens. Importantly, the report also includes personal stories of women veterans. Some recount military sexual trauma or intimate partner violence and the lasting impact on their mental health. Others describe being dismissed by healthcare providers or having difficulties accessing care in rural areas. Many of them share experiences of times when they considered or attempted suicide. The VA has made significant progress in women's health and research. That's in part thanks to watchdogs and advocates like DAV. We believe the VA is best positioned to provide the best and most comprehensive health care for all veterans. DAV will continue to fight to make that a reality for everyone who walks through VA's doors. With the help of DAV members, the veteran community, and leaders at all levels, this kind of advocacy can lead to meaningful, life-saving change. I encourage you to visit www.womenveterans.org to read DAV's latest report and find more resources for veterans and advocates. And if you're a woman veteran, we offer a way for you to share your own story. If you're here in the room, we have one-pagers for you available at the table outside. Women veterans have disproportionately high risk for intimate partner violence compared with women who didn't serve. According to the VA, nearly 1 in 5 women veterans using VHA primary care reported experiencing IPV in the past year. In fact, women veterans are 1.6 times as likely to experience IPV in their lifetime compared with civilian women. And there is a strong association between a positive IPV screening and a suicidal ideation and self-harm behaviors among women veterans using VHA services. IPV includes physical or sexual violence, stalking, and psychological aggression from a past or current intimate partner. Factors associated, and this includes digital, by the way, or online. Factors associated with IPV are younger age identification as LGBTQ+, and homelessness or financial hardship and a history of MST. There are also serious health risks for veterans who experience IPV, including physical injury, chronic pain, mental health conditions, reproductive health problems, housing, and employment problems and suicidal behavior. I'll now speak to our panelists or introduce our panelists. I'm happy to introduce our first speaker, Dr. Jennifer Kinetic. I knew I was going to do that. Sorry. She is the National Program Manager of the Megabus 5304 pilot program for care management social work services with the Department of Veterans Affairs. The pilot is exploring strategies to address intimate partner violence, or IPV, and sexual assault experienced by veterans with a focus on historically underserved areas and communities. Dr. Kinetic also is managing an anti-human trafficking pilot for VA. Dr. Kinetic is a clinical psychologist who has served women veterans who have experienced interpersonal trauma. She was a trainer, consultant, and member of the dissemination and implementation team for RISE, an IPV-focused treatment developed at the National Center for PTSD. Dr. Kinetic, the floor is yours.
Thank you so much for that warm introduction. It's a real honor to be here on this panel today with my esteemed colleagues, partnering with DAV and veteran survivors in doing this important work, this mission to end relationship health and safety concerns, to end interpersonal trauma, and prevention when we can, providing care when needed. My colleague already has provided such a rich description of the problem, so I can really focus on VA's mission. So just to highlight a few points, as has been said, interpersonal trauma is a problem that too many veterans are facing. While it impacts everyone, regardless of race, ethnicity, gender identity, sexual orientation, age, demographics, rurality, there are populations that are disproportionate risk. And as has been mentioned, women experience the highest rates of interpersonal trauma. There are other high-risk groups, as has been mentioned, historically marginalized communities, including LGBTQ+ people, people with diverse gender identities, people who identify as Native American, Alaska Native, experience some of the highest rates of interpersonal trauma. As has also been mentioned, veterans are at higher risk when we compare veterans with non-veteran populations. So what is VA doing about it? So, of course, we can't operate in a silo, and partnering with survivors, partnering with DAV, other internal and external partners is critical to this mission. I'm here, as has been mentioned, representing care management and social work services in the Department of Veteran Affairs. And so I'm going to share a little bit about some of our internal partnerships. Number one, whatever we do, the services we build, the care we strive to provide can't happen. It's not effective if people don't feel safe to come. and knock on the door and access care. And so step one in the VA is really striving to be a safe place, a trustworthy place where veterans can get the care they need. And I want to talk a little bit about how we're trying to do that. Number one, when we think about veterans who've experienced MST, MST for all veterans are screened for MST when they enroll in VA healthcare. Every VA facility and vet center has designated MST coordinators that are available to help coordinate needed care for those veterans. And MST support services are available for most former service members. There are other ways that we're striving to provide safety. Anyone who's experienced any kind of sexual trauma while on active duty is encouraged to talk to their MST coordinator. That coordinator can help them file a claim and work with their local VBA to get them support. Another critical way we're striving to build safety is through case management and coordination. And so one way we do that is through the National VA Liaison and post 9/11 military to VA case management program. This program helps transitioning service members by partnering with the National MST Office to ensure that a couple of things are happening. So number one, there's a lot of cross-training with those two programs, ensuring that case managers, social work, nurses at DOD, at military treatment facilities, and post 9/11 care coordination teams are trained up. So when a veteran approaches for care, they know where to go, who to connect them with. Another way that we're striving to build trust and safety for veterans is through consultation. So again, we can't work in silos. The National VA Liaison in post 9/11 military to VA case management program frequently consults with the MST program office on ensuring that this is happening. And then importantly, during the transition from DOD to VA healthcare, VA liaisons work again to establish what does the veteran need and ensuring that the receiving VA medical center is prepared to receive that veteran and get them connected. Another way we're striving to build safety and trust is through the National Intimate Partner Violence Assistance Program. We just had our 10th anniversary, the National IPVAP, and there are a number of ways we're doing this. Number one, through our philosophical approach. Our approach to treatment, we strive to be trauma-informed, and we strive to ensure that there is no wrong door to care, and this is critical. What does that look like for a veteran, for a woman who's coming to VA for care? If that person is feeling trust and safety with her nurse in the primary care clinic, she should be able to talk to that nurse about relationship health and safety, and that nurse connects the veteran to needed care. Perhaps the veteran's feeling most safe with the person who registers them, checks them in for their appointment. That frontline staff needs to know about our program, the National IPVAP, and get the patient connected to needed care. Another way we're striving to build this safety and trust is through an integrated approach. So as you've heard me speak today, we can't work in silos, and the program that we've rolled out over the last 10 years and continue to expand upon has integrated services. Number one, screening. As has been mentioned by my DAV colleague, identifying people who need this help is critical to providing needed care. And so screening is really important. And per VA policy at present, apologies for that, at present, all women under 48 are required to be screened, and our national IPVAP encourages universal screening, universal education around relationship health and safety, so all veterans are hearing the message that this program exists. And we also, as part of our policy, focus on screening in these high-risk groups, as I've mentioned, LGBTQ plus veterans, veterans who identify as Native American, Alaskan Native, and other minoritized communities. How else are we trying to build safety? So the National IPVAP, as part of our comprehensive program, as I've mentioned, has screening. Training is critical. We're constantly training up staff. We are also engaged, if a veteran comes to us for care, in collaborating with that veteran to develop safety plans that are veteran-centered, that reflect the veteran's values and preferences, and is culturally inclusive. We are also striving to provide safety and needed care to women veterans who've experienced interpersonal trauma through evidence-based interventions. There are a few that I'll share. RISE, as was mentioned, is a protocol, manualized treatment for veterans who've recently experienced intimate partner violence. The focus is very veteran-centered. We also have Strength at Home for veterans who are using violence or maybe at risk for using violence, another manualized treatment. Both protocols developed by a psychologist out of the National Center for PTSD. And then we have a number of other promising practices. So what's the way forward? So as was mentioned in my bio, the VA recently concluded a 2-year pilot. This pilot was connected with the Deborah Sampson Act, Section 5304, and the pilot looked at, in a focused way across 10 sites, what are the barriers and facilitators to providing care to veterans who are experiencing IPV and or sexual trauma post-military service? And so, and the focus of the pilot, we focused on historically underserved veterans, as defined by the legislation, was historically rural, highly rural areas, Native American veterans. We did expand that focus to include other minoritized groups to look at, how can we do better accessing, connecting veterans with needed care. That pilot completed in September 23. We submitted a congressionally mandated report, and when that is published, we look forward to sharing those findings and recommendations. So finally, I'd just like to highlight that the way forward for VA is to continue to collaborate, to continue to listen to veterans, as has been mentioned by my colleague, the culture is change is happening, responding to the needs of the changing demographics. And I'm really proud and pleased to be a part of this discussion today, and look forward to continued collaboration, and thank you for your invitation today. Thank you.
Thank you, Dr. Kinetic. Now, I'm pleased to welcome our next panelist, Jennifer Alvarado, a proud Navy veteran, DAV member, more importantly, just kidding, and veterans advocate. Jennifer enlisted at 19 years old as a hospital corpsman, 3rd class, and served from 2001 to 2006. The New Jersey native and mother of 4 served at Naval Station Great Lakes in Illinois, where she quietly endured repeated sexual harassment and domestic abuse. Jennifer has made it her life's mission to speak up for herself and use her voice to uplift other women. Through her own commitment to healing, Jennifer has found help through the support of DAV and shares her story in hopes of inspiring positive change. Jennifer?
Thank you, Naomi. First, I'd like to thank the Women's Congressional Policy Institute and the DAV for giving me this opportunity to be here and speak to you today. It's not easy to talk about our stories, but the story that I'd like to tell you about today is my experience with intimate partner violence while active duty and while veteran, because it is 2 different worlds, and it's not easy to navigate either one of them. And I think Naomi and Jennifer, they touched on some really important factors where we can find assistance. But one of the big things for me is I was not in the mental space that I needed to be in while I was active duty to even ask for help. I had an issue going to my leadership because I'm having to wear a uniform, make sure that I am squared away, and then I go home and I'm enduring physical, mental, and emotional abuse on top of having to be a mother. I didn't know how to navigate bringing those 2 worlds together to even ask for help. And when I did eventually get the nerve to ask for help, I experienced military sexual trauma. So that completely damaged that line for me to ask leadership or ask for help because I couldn't trust them. So as Jennifer stated, safety is a very important factor when it comes to people that are dealing with intimate partner violence. We're not safe at home. So in order to even create that bridge to ask for help, there has to be a safe space. If there is not a safe space, we are not going to come out. Most of us that are enduring intimate partner violence, I can't speak for everyone, but I can speak for myself, that I was enduring narcissistic abuse as well. And if you look at studies and you look at statistics, it changes the brain. It's not going to change overnight. Mental wellness and mental awareness has to be a factor. And if you have women veterans that are not able to put food on the table, care for their children, mental wellness is their last thing that they're thinking about. They're trying to survive, and they're trying to make sure that when they walk into that duty station, their uniform is crisp and they are hiding any and everything that they left at the door the morning before. It wasn't until I became a disabled veteran that I started to ask for help. When I got out in 2006 and I filed my initial claim with the VA, I knew something was wrong. I didn't know that I had battered women syndrome. I didn't even know that I had PTSD. But mentally, I knew something was wrong. And I applied for, a claim for depression. And that kind of sparked things off that I knew something was wrong, but I didn't know where to go. I didn't know where the resources were, and I didn't know where to find them. When I walked into my local Philadelphia regional VA hospital at that time, it was not a safe space. I endured catcalling when I walked in the building, and I had to avoid certain areas because it didn't feel safe to me. And I actually left the VA healthcare system for 8 years. And during that time, I found myself. I went through battered women's counseling through the VA hospital, and I still use those tools today. But during those 8 years, I had to get sick of my own self. I had to get sick of my trauma responses, because at the end of the day, one of the things that not a lot of people talk about is with intimate partner violence, I have not only hurt myself, but I have hurt my children. I have caused generational trauma through my military PTSD and military sexual trauma. I've hurt my family. My mom, my dad have worried about me and tried to help me along the way, but it wasn't until I looked in the mirror and I said, I need to do something, this is not working, that I seeked out true help from the VA healthcare system. And I actually walked into a DAV representative's office, and I slammed my medical records on his desk, and I said, I'm not leaving until you help me. I was so sick of being caught in those trauma responses and not knowing where to go that I just asked the first person for help, and it was my DAV representative. And that man will have a close place in my heart for a long time, because he put me in connection with Naomi, which led me to the women's report, which led me here. And now I'm here advocating for a demographic that is not often seen and not often heard. So it really is an honor and a privilege to be here. And I'm hoping that together with the Women's Congressional Policy Institute and the DAV and psychologists, I'm hoping that we can make real change, not just for female veterans, but, I have a daughter, and I don't ever want to think about the fact that if my daughter wants to join the military, that I have to worry about the things that I've been through and other women. So I'm hoping that today we can bring light to situations that really need to be here and be seen and be heard. So thank you very much for having me. I appreciate it.
Thank you, Jenny. As you hear, Jenny's got a very powerful story, and I'm so glad that you really have found your voice. Two topics we highlighted in DAV's report, Dr. Kinetic, is a common theme among women veterans, and it was military sexual trauma and intimate partner violence, or IPV, something that you just mentioned. Two issues associated with increased risk for suicide, and these are both areas you've worked in extensively over the years. Could you talk about your work and some things that you found specifically related to IPV and mental health in women veterans?
Thank you. Can you hear?
Is this thing on?
Great. Okay. Absolutely. So I appreciate you sharing that, that question about the connection between IPV, sexual trauma experience, and suicide. As I said in my opening remarks, we can't work in silos, and health concerns aren't siloed. The mind, the body, it's all connected. And IPV experience, sexual assault experience, increases the risk for suicide. So I would want to highlight, I couldn't say it clearly enough, that addressing relationship health and safety concerns is part of suicide prevention. When we look at murder-suicide, for example, according to the National Resource Center on Domestic Violence, 1 out of every 10 people who are murdered by an intimate partner. 3, there are over 10 murder-suicides each week, and over 60% of those involve an intimate partner. So in the VA, we approach this, strive to approach this from a comprehensive perspective and partnering closely with suicide prevention.
Thank you for that. And I'm glad you mentioned that about the connection with even murder suicide. We have justice-involved veterans that have dealt with intimate partner violence or other issues that contributed to ultimately what ends up being the final act. And I know last year, for the first time, I spoke my truth publicly in this event, speaking about my own homicidal ideations. And so that's something that I think is so important and does not really get enough airtime, for lack of a better word. Jenny, given the increased risk from intimate partner violence, one of our recommendations in the report is that the Department of Health and Human Services create a 3-digit number similar to 988 or 911, but for veterans in crisis, with a veteran option for the National Domestic Violence Hotline. Do you think that could help a veteran who may be experiencing IPV? And if so, how do you think it can help?
Thank you for that question. I actually do think that it could help quite a bit. As I said, when I was active duty and even when I was a veteran that wasn't seeking out help, when you don't know where resources are, you can't ask for help. And if you're not asking for help, nobody's going to know that you need it. So I do think that having a 3-digit number where it's a safe space for veterans, whether female or male, because males and females experience intimate partner violence. So I think having that number is more of a safe space than, some veterans, our VA facilities aren't always a safe space. So I think to have a 3-digit phone number to get that first point of contact could be very imperative to not only save lives, but to get that direct help to the veterans.
And I think, when you think about, sometimes people kind of don't really understand, well, what's the difference between, domestic violence and, and domestic violence in the military? Isn't it the same thing? And I think, to me, a good kind of explanation is it's almost like being in a prison within a prison, right? You're in that relationship and you just cannot get out. But you fear that if you go to someone to get help, then that's going to affect your, military career, or you feel like that, you just can't go to them for help at all. So, having a phone number that you can easily recall in a time when, okay, I think I might be able to get out now, I think would be helpful, right?
Absolutely. It would be tremendously helpful for a lot of women, because I think, like you said, when we hear domestic violence, a lot of people have this preconceived notion that it's just physical. Well, domestic violence isn't always physical. Sometimes it's mental, sometimes it's emotional, and within the military, it can even be financial. So I think that one of the big things to help veterans is having that 3-digit number, but also realizing that intimate partner violence is not simple PTSD of one event or one experience. It's actually compared to childhood trauma, so it is a more complex PTSD, and I think that having resources and having access to things that are veteran specific are exactly what we need.
Thank you. Two other important issues that are highlighted in our report relate to interpersonal violence among women veterans living in rural communities, and you mentioned it, Dr. Kinetic, and the safe storage of firearms. Owning guns is common in the veteran community, given our military experience, but increased rates of firearm suicide deaths are a real concern, and promoting safe firearm-related behaviors, especially during periods of crisis, is essential to reducing suicide among veterans. Dr. Kinetic, what can be done to raise awareness about the impact of intimate partner violence and to break down barriers for women veterans living in rural communities and help promote safe storage practices?
Thanks for that comprehensive question. So there are a number of things. So when I think about risk mitigation, risk management around IPV, I mentioned in my opening remarks that one of the core aspects of the national IPVAP, the National Intimate Partner Violence Assistance Program, is providing veteran-centered safety planning. And so I think, as to your point about veterans in rural communities, veterans are unique. We cannot, it's not a homogenized group. We can't generalize about a veteran's preference or lifestyle. And that is reflected also in where they live. Everyone has unique needs. And so part of risk mitigation, suicide prevention, again, is to, number one, educate regarding what does relationship health and safety look like. As you mentioned, Jenny, IPV spans, there's a continuum of behaviors, and for many people, it doesn't start at an extreme level, and it can build over time, and people learn to adapt, and from my perspective, veterans are among the most resilient group I know, and so they adapt, and over time, if you're in a situation, it becomes normal. And so part of what we're doing at VA to raise awareness and to do suicide prevention, particularly for veterans with relationship health and safety concerns, is to teach about, again, what does a healthy relationship look like? How do you know when the line's been crossed for you? And would you be open to engaging in a safety plan, developing a safety plan for yourself that reflects your own personal needs and preferences? And that's a core part of prevention. And also, we work closely with peer support specialists in VA. And often, like to your comments earlier, Jenny, it's really hard to ask for help. It's hard for lots of reasons, because when you're experiencing relationship health and safety issues, IPV, sexual violence, there is real fear that if you report, you'll be less safe. And the research bears that out. When people leave, risk to being killed by an intimate partner increases significantly for that whole year after leaving a situation. And so VA and the National IPVAP is mindful of that. And so safety planning needs to be always veteran-centered, honoring veterans' choice, and engaging in with peers as needed.
Thank you. One of the things that you said was, well, actually, several of the things you said mentioned, if you have the veteran and you're speaking to the veteran, that assumes that they're tethered, that they're attached to VA. But as you mentioned before, we have veterans that live in rural communities that are, say, on Indian reservations, right? That are really not tethered in that community. And so, and I know you were expecting this, but what is VA doing to really reach out to those veterans?
So I mentioned in my opening remarks, and I think it's in my bio, that VA recently concluded a 2-year pilot. And it's connected with Section 5304 of the Dever-Sampson Act. And that 2-year pilot had us look in a focused way on, just to your point, Naomi, engaging veterans in historically underserved areas and communities. That was defined as those in rural, highly rural areas in the insular islands. We had 10 sites, and a major part of the project was looking at barriers and facilitators to engaging veterans in needed care. And we don't want to just serve the veterans who are already registered. We want veterans to come and choose VA. That 2-year pilot, we went out to each of the 10 sites. We interviewed veterans served by the pilot, staff, and the leadership of those 10 medical centers, including in the Pacific Isles, where it's quite remote and insular for many veterans, where they don't have access to local rape crisis, local shelters, or they're full. And specifically when we look at issues in the rural areas, if there are rape crisis centers in the community, if there are shelters in the community, they may not be accessible. With COVID, there's been a huge increase in, significant increase in IPV, and shelter accessibility can be a challenge. So we're really looking in VA at how can we outreach. And as I mentioned, the report has been written, and when it's published, we look forward to sharing more of those recommendations.
I'm waiting with bated breath. Trust me, I can't wait. Jenny, as you transitioned into civilian life, what are some federal programs that really helped you the most?
To be honest, there weren't too many federal programs that did help me. When I got out, I went in, like you said, as a young single mom, and when I got out, I was married with 2 children, and there was no one to guide me. There was no one to direct me in any places at all. So I went through, our basic transition program, which I believe is a 2-day class, but there's no medical, there's no one asking you if you've experienced this or experiencing that. What I wish I would have seen, through the transition is I wish that there would have been a connection between the VA and the DoD, because if I had had that connection, if there was someone in the middle between the DoD and the VA, I would have had an opportunity to say, hey, I also have these other things going on. I don't know what they are. So I would like to see, when we talk about the report, as Naomi said, we showed a lot of gaps, but we also showed a lot of solutions. And I do believe working on that transition program and getting the DoD and the VA connected would make a huge difference. Like I said, I was not mentally in the position where I could even look for help. I didn't want to. I was decorated with shame and guilt and a lot of other things. So the last thing that I wanted to do was look for help. I wanted to go home. That's all I wanted to do. I wanted to take my kids and I wanted to go home. And it took me years. My journey has been about 20 years. So having specific things in that transition period would have helped a lot. And I do believe that if the VA healthcare system had certain designators within their screenings that would red flag certain phrases or certain words, I do believe that maybe my situation could have been caught a little bit sooner.
Thank you. Yeah, sure, go, please do.
I'm glad you brought that up. And just to highlight one resource that we do have now in place for veterans who are in that transition period, our post 9/11 transition and case management managers. So we can get veterans connected. So that's an option now. And also the MSD coordinator directory. As I mentioned in my opening remarks, an MSD coordinator is assigned to every medical center and can be supportive and just help veterans navigate those challenging times of transition.
Thank you, Dr. Kinetic. And now I would like to invite our online audience to submit questions. Maybe you have some questions. You do?
No, just in person.
Oh, in person.
Sorry.
In person. Do we have any questions in the audience? Yes, ma'am.
Hi. Well, I'm in the reserves, And I'm curious because with the reservists, they always have like a sharp representative. So that's something that I've kind of found solace in, which is very convenient because it's usually a woman, which is comfortable for me. I was curious on the active duty side, is there no representative usually at a unit for that is a sharp rep, sexual harassment and prevention?
Thank you for that question. So I'm not a DoD expert. However, I can tell you that they do have representatives in the active duty component. If you just go to, you said you're in the reserves, which branch? Thorough branch? Army. I'm sorry. I'm Air Force. There's family readiness. You go to that section. I know for the Air Force, it's called the Airmen and Family Readiness Center, and it's at each base. And you just connect with them, and they'll connect you with that representative. But you're right. There is a huge issue. And I'm glad you bring up reserves, if you don't mind going off a little bit. But I'm glad you bring up reserves because that is so important. I was talking to one of our members, and she was talking about how when she served on the reserve, she went over to Iraq or whatever. She deployed for like a year because Army deploys for about a year at a time, came home and was dealing with some things and couldn't even get a light bill in her name, couldn't even get, because she had no rental history. She had no history, credit history or anything like that. And so, that's another issue or another, I would say, arm that needs to be looked at. And that is also our reserve, guard and reserve component. So it's good to hear that there are programs. Any other questions? I thought I saw another hand up. Yes, ma'am.
Can everyone hear me? Okay. Thanks. So first, I just wanted to say thank you all for the work that you're doing and for your service. I'm over in VA Central in Office of Research and Development, specifically working on women's health research. So one thing I'm curious about is what DAV is doing on the other end. So not focusing on individuals who experience intimate partner violence, but on the other end, and maybe trying to decrease or even prevent rates of intimate partner violence or military sexual trauma from happening in the first place. So you're wanting to know what DAV is doing about that? So DAV's mission is just focused really on service-disabled veterans, and so I think education is a huge piece of it. We really work hard to ensure that the information that we get is vetted and is evidence-based, and we like to hear from our members what's going on, because how are you going to know how to change something if you don't hear about it or if you don't look at the history of it? So we beat the drum. We really do. We beat the drum, and we have these conversations. We go up on Capitol Hill. We open up dialogue, and really, we love the Office of Research. Dr. Yano, big fan. Almost every week.
Yes, big fan of Dr. Yano, and really, she also, or your specific area does help inform us on what can be done, but it's not something that we really kind of have a program to do. It's just this is what we do because we are the veteran. We've experienced this, and so that is how I think help to inform positive change. Sure.
Good question, by the way. I'm actually really glad that you asked that, because one of the things through doing all of this is I do bring up the fact that at some point somebody has to hold the EOD accountable, because if you don't stop where it starts, it's going to continue to happen. And as Naomi stated, you know, in this report that the DAV did, there's veterans that served in the 70s that were experiencing things that we're experiencing today. But what I wanted to answer you is, you asked how the DAV is, you know, bringing awareness, and that's exactly what they're doing. Without the DAV, I wouldn't even have known about a lot of the different programs. So I think that's their intricate part, is to bring awareness to the veterans and let us know. And also, the DAV is really big on community, and I think through all these studies, we've realized that peer connection is where we find these veterans that need to come out of hiding, and DAV does a phenomenal job with that. And, you know, through all this, the only reason why I kind of got really connected with the DAV is because they help all veterans. They don't discriminate. There is no, you don't have to have a membership. I was an angry vet at one point, and I didn't think there was anybody out here helping veterans. And then look at the room that I'm in, and I meet people like Naomi and Dr. Jennifer here, and it does make a huge difference. And while they might not be able to nip the problem in the bud where it's happening, they are doing any and everything on their end to make sure that veterans like myself are able to connect out in the community, and also within the VA and within the DAV, to make sure that not only do our claims get taken care of, but also our mental health. Because at the end of the day, you can give me all the resources that you want. You can help me get out of that house. You can help me get out of that situation. But if you're not fixing the mental health issues that I gained from that abusive relationship, then I'm going to go right back into that relationship. So having that peer-to-peer relationship and community, I think the DAV is really making the biggest strides out there that I've seen. So.
Sure. Thank you. Thank you for your service at the VA and the important work you're doing. I just want to highlight for those who are not familiar with what VA is doing to address this question around veterans who are using violence or maybe at risk of using violence. The Strength at Home protocol has been rolled out, and we continue to train clinicians in this. Developed again by Dr. Casey Taft out of the National Center, Boston. It's designed for veterans who may have PTSD and also may be engaging in violence with their intimate partner, again, at risk. They also have there's a version now that is focused on the couple. And so I just like to let veterans know those resources as well. And if you need to get connected with those treatments, connect with your local intimate partner violence assistance program.
Should I help?
Yeah, go ahead.
I just had to touch on that because it's really important. You brought up something that I actually wrote in my outline. I've not always been a victim. You know, as somebody with military PTSD, I've been a perpetrator. You know, I've been in that relationship where trauma responses are playing off of trauma responses. So while, yes, I am a victim, I've been on the other end of that. So to know that there's a program that helps the relationship as a whole, that is a key issue that needs to be fixed. Because I think when it comes to intimate partner violence, I can't tell you how many times I've gone back to that same situation. I can't tell you how many times I've gotten a restraining order and then dropped it. And if I would have had access to maybe the full partnership getting the mental health care services that they required, I think that it might be different. So I appreciate that.
I'll also add vet centers are also a critical component, because vet centers not only are for veterans, but they're also for active military. Yes, sir?
Hello, my name is Aaron. I'm a AAAS fellow sponsored by the American Psychological Association. I'm currently a health and disability fellow in Senator Tim Schumer's office. I'm coming from about 5 years of service at VA. And so I want to thank both of you for being here today. Actually, I have a question for each of you. Ms. Alvarado, thank you so much for sharing your story. And congratulations on breaking that cycle of abuse and violence. It's really difficult to do, and I really appreciate you sharing that journey with us today. It was really sad to hear about your break from VA because of the experiences that you had. I will say my last VA, at the entrance, we had signs about not catcalling and treating people with respect. I'm wondering what eventually made you feel comfortable re-engaging with VA services, if you feel comfortable sharing. And Dr. Kinetic, I'm wondering how the recent of the past about year and a half kind of national slowdown in hiring, or most sites going to an FTE zero policy, has affected the ability to hire providers who specialize in women's health and safety.
Thank you very much. I appreciate that. One of the things that I've learned through this process is not everybody is meant to tell stories.
Sometimes we have to tell our story in order to allow other people to feel safe to tell their own stories, even if it's through a provider. Me leaving the VA healthcare system was imperative. I'd be sitting here before you if I didn't leave the VA healthcare system. What brought me back was the Philadelphia VA got a female director, and she made some amazing changes, and she made it a safe space. Some of the things that she did to do that was getting rid of the smoke deck that was out front. I think that was a gathering point for a lot of veterans. And let's face it, our older male veterans, they lived in different times, and what was acceptable then is no longer acceptable now. So I think by creating a safer environment, by getting rid of, the smoke deck and moving the Women's Health Center to a different floor where you can use separate elevators, it made a huge difference. And she is extremely active when it comes to making sure that women veterans feel safe in her facility. So I think having a female director who is a veteran and has experienced some of the things that we're talking about today, huge difference. Thank you.
For your service, VA, and for that question. So I'm not on the HR side of things at the VA. I can't speak to hiring practices. I can just tell you from my own perspective in our office and with all the other program offices at the VA with whom we collaborate, Office of Tribal Health, Office of Rural Health, Office of Mental Health, Suicide Prevention, LGBTQ+ National Office, Center for Minority Veterans, to name a few. No one's relenting. The mission remains the same. We care passionately about the work we're doing, and we'll keep on doing it. And we want to hear from veterans and get your feedback and yeah, thank you.
Any other questions? I do have one, I think, are we at time? I do want to speak about, so one of the things that was mentioned was, intimate partner violence is not just limited to just women, or women veterans specifically here that we're talking about, but also males, right? But I do want, Dr. Kinetic, if you can speak on the unique challenges that women face, specifically when it comes to the reproductive health cycle and how that affects a woman and their responses differently than a male. Does that make sense? So if you have a patient that comes in and two have experienced the same thing, and maybe a woman is going, the woman might have going through menopause or just had a baby or something like that. If you can kind of speak to how she would process things maybe a little bit differently than the male patient. Yeah.
Thank you for that. And I'll highlight, I'm not a physician, I'm a psychologist, but I can certainly speak from that perspective. I think I go back to, we strive not to provide any kind of cookie cutter treatment. That doesn't work. It has to be tailored to the veteran's needs and preferences. That includes their culture, that includes their spiritual framework, that includes their medical needs. And we know that medical needs are part of safety planning. A strong safety plan is building in, like if you're preparing to maybe exit a situation, do you have your medications? Do you have your birth control? Is your partner withholding that as part of your experience of IPV? Is your partner engaged in healthcare coercion? And so you have reduced access to your maternity care. We collaborate also with maternity care coordinators at VA and Women's Health to ensure that veterans are getting their needs met.
Thank you so much. That's so important. I'm glad you mentioned that. Jenny, you were really young when you enlisted, and now you're a mom, and you found your strength. Do you have any advice for someone that might be here, listening online, listening to your story? Do you have any advice that you really would like to give to her?
But I think the first thing is there's never going to be a right time. You, at some point in time, have to jump. I've made more excuses than excuses over the last couple of decades, and just jump. You don't have to tell your story, but ask for help. You may run into situations where it might not look the way that you wanted it to, but taking that initial step and asking for help, whether, like you said, whether it be a provider or a nurse or even a fellow veteran or a friend, talk to somebody. When you are enduring physical, mental, and emotional abuse, the amount of shame and guilt that you carry often keeps you from asking for help. But it kept me 20 years locked into a cycle that I caused a lot of self-suffering that I didn't need to go through. And had I spoke a little bit more when I was, afraid, I think that it could have kept me from staying out of, trauma responses and 20 years of self-suffering. So speak, even if it's not in a forum like this, if it's to a friend or even a neighbor or a total stranger walking down the street, tell someone. Tell someone a little bit, and I guarantee you it's going to open the door for you to be able to get the help and the services that you need and deserve. And there was one thing that I wanted to touch on. I just recently did an article with Task and Caucus, and it was about the Army Emergency Relief. They are now expediting financial assistance for victims of intimate partner violence, and I am hoping that this policy gets put across for all branches. And while it's not easy to navigate, I think that that's a start. And for the Army to provide financial assistance to a veteran or active duty member who might be experiencing financial abuse or domestic violence, I think it's a start and it's a step in the right direction. And I'm hoping that the other branches follow suit, because it starts in places like this and it starts with people like this. And I'm just grateful for the opportunity. And like I said, talk. That's all you have to do is just talk.
Awesome. Dr. Kinetic, I also want to give you some room if there's something that you would like to add.
Thank you. I'm glad to hear you say that. Jenny's talking about talking, and VA is listening. We are committed to this mission, and we are sit on, VA sits on the Gender-Based Violence Federal Interagency Work Group. The focus, the mission of that group is to end gender-based violence. We're committed, and I would just leave the message to veterans who are watching: there is no wrong door to getting care. Talk to the staff with whom you connect, and they will get you to us.
I also want to remind those that are here that the DAV's Women Veterans Report, we do have some that are outside on the table, and some one-pagers for you to take back. And there are over 50 legislative ideas in there for you. And if you have any questions at all, please feel free to reach out to me or anyone from Team DAV. And with that, I will hand it back on over to Cindy. Thank you.
Well, thank you so much to each of our speakers for inspiring us. There are so many ideas that have come up today, so many issues that need to be addressed. And we have the DAV report with legislative opportunities. And thank you also to Naomi for such a wonderful job of moderating this discussion. So another round. And I am, excuse me, I'm confident that this briefing has provided so much, so much, what is the word I'm looking for? Well, first of all, a better understanding, but also so much food for thought and so many possibilities for offices. We talked about this before the briefing. Not everything has to be a bill. There are so many things that can be done. We talk about helping to reduce stigma, to just getting things visible and out in the open. So for those who work for members or senators here, there are an endless number of things that you could be doing and your boss can be doing. And we know that the DAV report and this briefing will serve as a resource for members and staff for the next Congress. Forget that we're just about done. This conversation has been recorded and should be available for viewing on our website at wcpints.org. Probably it'll be next week, given it's Thursday. And we do have a short survey after today's discussion. You can access it through the QR codes. I see some on the walls, some on the backs of seats. We hope people will take a moment to respond, and then also to encourage anyone attending remotely, you will get the survey as soon as this event ends. So please also answer it. It helps us to know topics for the future specific to women veterans, but also more broadly. And then thanks again, of course, to the Bipartisan Women's Caucus leadership. A number of their staff were here. I saw a couple in the back. And also to Otsuka for their financial support for this, and also for all the work they're doing on women's mental health. And then finally, of course, my thanks to the WCPI team, Alyssa Innes, who did so much of the work for this event, Afnan Adam, Krista Selno-Camarda, Annabelle Green, Catherine Thompson, and Krista Faith Gonzalez for their work to make this briefing possible. Thank you so much for joining us.